Hello and welcome to our presentation on water and sodium physiology and hypernatremia. Before going to the topic of hypernatremia, first I will talk about the water balance that indicates sodium physiology indirectly. The hypothalamic, neurohypophyseal and renal axis normally maintains water balance during variation in the water intake and non-renal losses of water. The regulation of water balance is governed by high gain feedback mechanism involving the hypothalamus, neurohypophysis, and the kidneys. Receptors in the hypothalamus, they sense plasma osmolarity. When the osmolarity increases to levels above a physiologic threshold, that is more than 295 milliosmoles per kg of water in most persons, there is increased secretion of vasopressin in the neurohypophysis. It will lead to triggering of the thirst and urge to drink water. And vasopressin binds to the receptors in the kidney that decreases the excretion of water, and greater fraction of filtered water is returned to the body, to the blood. In this diagram, you can see if the plasma osmolarity increases, there is positive feedback of receptor activation in the hypothalamus that will cause arginine vasopressin or ADH secretion and increase in the level of plasma vasopressin. This vasopressin causes the activation of the receptors in the kidneys and it causes reabsorption of the water and inhibition of water excretion. It will lead to decrease in the plasma osmolarity and the loop is completed. And even the osmoreceptor activation will cause increase in the thirst that will lead to drinking of water that will also cause the plasma osmolarity to decrease. There are two types of regulations of body water. One is according to osmolarity, as I told, and the another one is according to the blood volume status of the body. If the circulatory blood volume is too low, there will be baroreceptor activation in the carotid sinus aortic arch in the left atria. That will cause positive feedback of arginine vasopressin synthesis and it will cause arginine vasopressin release. And the receptors in kidneys will cause water reabsorption and increase in the plasma volume. And the effect of volume status, it is a composite mechanism. When there is decrease in the extracellular fluid volume, it causes three things. One is decreased blood pressure, one is increased sympathetic stimulation, one is decreased fluid or sodium delivery to the distal tubules. All these three will lead to increased renin secretion. That will cause increased angiotensinogen 2 secretion. And this angiotensinogen 2 will cause few effects like constriction of the blood vessels, increased absorption of sodium by proximal tubules, increase in the thirst, and increased secretion of the aldosterone. Even few other mechanisms like increased plasma concentration of potassium and decrease in the plasma concentration of sodium will also cause increased secretion of aldosterone. All this will lead to increased reabsorption of sodium from distal tubules and increased secretion of potassium. These all will occur in a feedback loop. This is a simplified graph flowchart. It shows when there is a decreased true or perceived extracellular fluid volume, there will be decreased stimulation of baroreceptors that will cause increased renin, angiotensin, aldosterone system activation, increased sympathetic nervous system activation, and increased ADH. It will cause sodium and water retention, and it causes gain of water leading to normal extracellular fluid volume. And increased ADH will also cause water retention leading to normal extracellular fluid volume. And in the opposite wing, if there is increased extracellular fluid volume, it will cause increased baroreceptor stimulation that will cause suppression of the RAS system and suppression of the sympathetic nervous system that will cause sodium and water excretion and decrease in the extracellular volume leading to normalization of the volume. Coming to nephron, it is the important site of action of all the receptors and all the regulation of water and sodium balance. We know it consists of glomerulus, proximal convoluted tubules, proximal straight tubules, thin descending limb of loop of Henle, thick ascending limb of loop of Henle, then macula densa, distal convoluted tubules, connecting ducts, and collecting ducts that consist of cortical and outer medullary, inner medullary collecting ducts. The loop of Henle segments, they generate a corticomedullary osmotic gradient through the process of countercurrent multiplication. Connecting tubule and collecting duct segments, these are segments that manifest regulated water transport through the action of vasopressin to regulate the water channel aquaporin 2. The macula densa is the point along the nephron where contact is made with glomerulus to the same nephron. This provides a feedback signal that regulates the glomerular filtration rate to stabilize the sodium chloride concentration in the luminal fluid delivered to the distal convoluted tubule. That is, if the sensing of sodium is less in macula densa, then there will be more glomerular filtration, leading to normalization of sodium levels in the tubular fluids. And in reverse, also, if there is high sodium in the tubular fluid, there will be less filtration. And there are a few receptors that is very pertinent to our topic of sodium and water balance and the disorders of sodium mechanism. The most important one is arginine vasopressin receptor. There are two types of receptors of ADH. One is B2 receptors. The symbol is arginine vasopressin receptor 2. This B2 receptor is a G protein coupled receptor. It causes, and the activation of this receptor will cause intracellular level of cyclic AMP increase. And V1 receptor is primarily present in blood vessels, and it will cause the receptor will mediate the effects of vasopressin on the renal blood flow. In this graph, we can see the effect of vasopressin. As the vasopressin concentration is increasing in blood, there will be urine concentration will be increasing from dilute urine, concentrated urine. Why this happens? As vasopressin increases, there will be concentration of urine as water excretion decreases. But the osmotic clearance remains the same. So gradually, there will be concentrated urine excretion due to vasopressin. One important channel is BUMETANIDE-sensitive sodium-potassium chloride post-transporter. It is present in the thick ascending limb of loop of Henle. What it causes? The transport of sodium and chloride from the lumen is mediated by this. Vasopressin upregulates this co-transporter in at least two ways. One is short-term regulation, one is long-term regulation. But short-term regulation, it causes vesicular trafficking of the receptors. And what is long-term consequence? It is increasing the expression of these receptors. This is one gene called SLC12A1. Upregulation of this co-transporter generally does not affect salt excretion because the thick ascending limb is upstream of the macula densa, which compensates for the change in salt delivery by adjusting the glomerular filtration, as I told before, due to glomerulotubular feedback. But the diuretic, bumetanide, and other loop diuretics, they increase the salt excretion because they inhibit the channel in the macula densa, thereby blocking the feedback. Type 1 Bartter syndrome occurs when there is a loss of function mutation in the SLC12A1 gene. It is manifested by a salt losing syndrome rather than by a simple defect. So in this Bartter syndrome, there will be salt loss and water balance will be same, but there will be overall hypovolemic. Another channel is thiazide-sensitive sodium chloride co-transporter. This channel is present in the DCT, transport salt at a higher rate, but it is impermeable to water and thereby contributes to the dilution of the tubular fluid. The luminal fluid is dilute relative to blood plasma in this segment. What vasopressin does, it exerts its effect on the salt transport by upregulating this receptor, this co-transporter. And aldosterone increases the abundance of this co-transporter in the DCTs. And when there is inactivating mutation in this co-transporter, there occurs Gitelman syndrome, which will be manifested by hypotension due to water excretion, hypokalemia due to potassium loss, hypomagnesemia, hypocalciuria, and metabolic alkalosis. Polyuria, which also occurs in patients with this syndrome, is primarily a result of hypokalemia. This is a picture showing the location of these channels. The sodium potassium chloride co-transporter occurs in the thick ascending limb of loop of Henle. The sodium chloride co-transporter that is present in the DCT. This is the luminal membrane. This is the basolateral membrane. There are few water channels. They are called aquaporins. The first water channel to be discovered was aquaporin 1. This channel is expressed in the proximal tubules and thin descending limb of loop of Henle. The thin descending limb, it plays an important role in the countercurrent multiplier mechanism, allowing a rapid osmotically driven exit of water from the lumen, thereby concentrating the luminal fluid. This is constitutively expressed in the kidney and it is not regulated by vasopressin. The most important channel is aquaporin 2. It is expressed throughout the collecting duct system, the region of renal tubules where vasopressin actually regulates the osmotic transport of water. It mediates the apical component of transepithelial water transport. Its regulation by vasopressin controls the overall rate of water permeation across the collecting duct epithelium. Most of the patients with non-X-linked nephrogenic diabetes insipidus have mutations in the aquaporin 2 channel. The short-term regulation of aquaporin 2 occurs as a result of membrane trafficking. Trafficking means there will be stimulated exocytosis, inhibited endocytosis, and the intracellular channels will go to apical membrane in the cells. The long-term regulation of aquaporin 2 occurs as a result of vasopressin-induced increase in the total abundance of the protein channels. Half-life of these proteins and number of these channels are also increased by vasopressin. So the dysregulation of aquaporin 2 channels plays a central role in both polyuric disorders and the disorders associated with delusional hypernatremia. Polyuric disorders due to abnormalities in this transport are intrinsic to the kidney and referred as nephrogenic diabetes insipidus syndrome. Acquired nephrogenic diabetes insipidus syndromes are much more common in clinical practice. In this diagram, you can see when there is abundance of vasopressin, it will act on vasopressin B2 receptors that will cause increased cyclic AMP, activation of protein kinase, and transcription factors are increased for aquaporin 2 channel transcription. And even the aquaporin 2 channels that are inside the vesicles, there will be exocytosis and inhibition of endocytosis and trafficking of these channels from cell to the apical membrane or lumen. Via these channels, water comes across the tubular epithelium, and by aquaporin 3 and 4, this water come out to the interstitial space. Another important channel is vasopressin-regulated urea channel. In the inner medullary collecting duct, vasopressin rapidly and reversibly increases the transepithelial urea permeability, allowing urea to exit and become trapped within the countercurrent exchange system. Accumulation of urea in the medullary interstitium will cause high osmolality in the inner medulla, and this high urea permeability of inner medullary collecting duct is attributable to two channels, that is urea transport A1, urea transport A3. Genetic deletion of this UTA1 and UTA3 channels in mice reduces the urea permeability and eliminates the corticomedullary urea gradient that will lead to concentration defect in the kidneys. It is the diagram showing the same. This is interstitium, this is lumen. Vasopressin acts and increases the adrenal cyclase and increase in the cyclic AMP levels. Protein kinase A that will lead to increased synthesis of urea transport A1 channel. Urea comes from the lumen and enters the cell and passes through the cell to interstitium through urea A3 channel. The last one is epithelial sodium channel. The transport of sodium ions out of the lumen of cortical collecting duct is strongly and rapidly upregulated by vasopressin. The epithelial sodium channel is heteromeric complex consisting of alpha, beta, and gamma subunits. The abundance of beta and gamma subunits of epithelial sodium channel is actually increased by vasopressin in a period of hours to days. Even aldosterone selectively increases the abundance of alpha subunits of proteins. So both aldosterone and vasopressin will increase the epithelial sodium channel expression. The overall regulation of transport in the cortical collecting duct appears to be synergistically dependent. Increase in vasopressin concentration actually do not generally result in reduced excision of total solute because of compensatory effect of renin, angiotensin, and aldosterone system. The deletion of epithelial sodium channel is associated with abnormality in the regulation of external fluid volume, that is salt balance, rather than the abnormalities of water balance. Type 1 pseudohypoaldosteronism is due to loss of function of mutation in the subunit genes of epithelial sodium channel. Now coming to the topic of hypernatremia. With this background knowledge of all these receptors and the all the osmotic regulators. The renal concentrating mechanism is the first defense against water depletion and hyperosmolality. If the urine is inadequately concentrated or if inordinate amount of hypotonic fluid are lost and these are not replenished, hypernatremia results. Patients fall into three broad categories depending on the total body sodium or volume. First one is hypernatremia with low total body sodium. These patients sustain losses of both sodium and water, but with a greater loss of water than the loss of sodium. They manifest signs of hypovolemia, such as orthostatic hypotension, tachycardia, flat neck veins, poor skin turgor, dry mucous membranes, and sometimes altered mentation. The causes reflect primarily hypotonic water losses from the kidneys or the GI system. In the latter case, the urinary sodium will be very low. Then the second one is hypernatremia with increased total body sodium. This is the least common form of hypernatremia. It usually results from hypertonic solution, ingestion such as 3% NS, the administration of sodium bicarbonate for the treatment of metabolic acidosis or hyperkalemia or cardiorespiratory arrest. It may also happen accidentally in dialysis against a high sodium dialysate or from consumption of salt tablets. Then the third one is hypernatremia with normal total body sodium concentration. Most patients with hypernatremia secondary to water loss appears euvolaemic with normal total body sodium concentration because loss of water without sodium does not lead to over volume contraction. Water loss per se need not culminate in hypernatremia unless it is accompanied by water intake, as I told before. Such hypodipsia is uncommon. Hypernatremia usually supervenes only in those patients who do not have any access to water or who have a neurological deficit that will not allow them to seek water. External water loss occurs from the skin and respiratory tract in febrile or other hypermetabolic states. The defense against hyperosmolality requires both stimulation of thirst and ability to respond by drinking water. The renal losses of water that lead to euvolaemic hypernatremia are consequence of either a defect of vasopressin production or release, that is called central diabetes insipidus, or even failure of the collecting duct to respond to the hormone, that is nephrogenic diabetes insipidus. Who are the patient subsets? Those are at increased risk of severe hypernatremia. One is elderly patients or infants. Second is in patients who receive hypertonic infusions, tube feedings, osmotic diuresis, lactulose, mechanical ventilation. Third is altered mental status patients. Fourth is uncontrolled diabetic mellitus. Fifth is underlying polyuric disorders. Signs and symptoms of hypernatremia are usually CNS manifestations like altered mentation, lethargy, irritability, restlessness and seizures, muscle twitching, hyperreflexia, spasticity, even fever, nausea, vomiting, labored respiration also can occur in hypernatremic patients. So what is the prognosis? In adults, serum sodium concentration above 160 millimoles per liter is associated with 75% mortality, while in chronic hypernatremia, mortality is around 60%. Actually, hypernatremia in adults occur in the setting of serious diseases. So the high mortality figure may reflect the underlying disease rather than the hypernatremia. This is a flowchart showing diagnostic approach to hypernatremia. First thing we should do is assess the volume status, whether he is hypovolemic or euvolemic or hypervolemic. If the patient is hypovolemic, there will be definitely low total body sodium and low total body water and total body sodium will be low. Then we should see for urinary sodium. If it is more than 20, definitely there is urinary loss of sodium. In osmotic or loop diuretics, patients who are getting this or some kind of obstruction in kidney and in intrinsic renal disease patients. And if the urinary sodium is less than 20, then there should be some external losses of water, excessive sweating, burn patients, any fistulas or diarrhea patients. And if the patient is hypervolemic, urinary sodium will be more than 20. And the causes may be primary hyperaldosteronism, Cushing syndrome, hypertonic dialysis, hypertonic sodium, bicarbonate infusions, or sodium chloride tablet injections. And the third one is euvolemic patients. The total body water will be low, but the total body sodium will be normal. and urinary sodium will be variable according to the intake of that patient. It may be due to renal causes or extrarenal causes. Renal causes are mainly diabetes insipidus and hypodipsia in psychiatric illness patients. External losses are due to insensible losses via respiratory and dermal pathways. So what are the treatment options of hypernatremia? First is correction of the volume deficit. Isotonic saline is infused until the hypovolemia improves, and some patients are hypotensive. Until the hypotension improves, isotonic saline will be given. Then we have to treat the cause of volume losses, like we have to give insulin in hyperglycemic patients. We should try to relieve the obstruction in kidneys and removal of the osmotic diuretics if the patient is taking like mannitol. The second part is correction of the free water deficit. We have to calculate the free water deficit, and then we have to replenish hypotonic fluids like 0.45 normal saline, 5% dextrose or oral water, replacing deficits and the ongoing losses. What is the treatment option of hypervolemic hypernatremia? First thing is we have to do is the removal of sodium, either by discontinuing the offending agent. Then we can give diuretic like loop diuretics, and finally, if we are not able to do all this, then hemodialysis is the option. In isovolemic hypernatremia, the major disease is diabetes insipidus. Definitely, we should know something about the types of diabetes insipidus and the treatment options. One is central diabetes insipidus. About 50% of cases of the central diabetes insipidus are idiopathic in origin. The rest are caused by tumors like metastasis from brain, breast, craniopharyngioma, pinealoma, some trauma, cyst, granulomas like TB, aneurysms will also cause central diabetes insipidus. What are the signs and symptoms? Polyuria, polydipsia, nocturia, high serum osmolality, and low urine osmolality will be there in diabetes insipidus. Then nephrogenic diabetes insipidus, there are two types. One is congenital, one is acquired. Congenital nephrogenic diabetes insipidus clinically expresses itself fully only in males and subclinically in females. It is X-linked dominant inheritance. The major defect lies in the V2 receptor. Autosomal recessive form of nephrogenic diabetes insipidus is caused by mutation of the aquaporin channels. The infants present with hyposmolar urine in the face of severe dehydration, hypernatremia, vomiting. Acquired nephrogenic diabetes insipidus, it is more common, is rarely as severe as congenital nephrogenic diabetes insipidus. Most patients, the ability to elaborate a maximally concentrated urine is impaired, but the urinary concentration mechanism are partly preserved. So the daily urinary volumes are less than 3 liters in comparison with the congenital nephrogenic diabetes insipidus, where the urinary volumes may be up to 8 to 10 liters per day. So what are the causes of acquired nephrogenic diabetes insipidus? Advanced chronic renal insufficiency of any cause can lead to resistance to ATH associated with the hypotonic urine. The mechanism of concentrating defect is multifactorial. One is disruption of the inner medullary structure or local alteration in the medullary blood flow, which is seen in tubulointerstitial diseases, sickle cell diseases, or any analgesic nephropathy. What the sickle red cell does, they occlude the vasa recta and cause papillary damage. The resultant medullary ischemia impairs the sodium chloride transport in the ascending limb. In long-standing sickle cell disease, medullary infarcts occur. The concentrating defects become irreversible. Hypokalemia causes an abnormality in urinary concentration by stimulating water intake and lowering the interstitial tonicity, which relates to a decrease in the thin ascending limb sodium chloride reabsorption. This also decreases the ATH-sensitive aquaporin 2 channel activity. Hypokalemia from any cause like diarrhea, chronic diuretic use, primary aldosteronism may be associated with reversible defects in urinary concentration. Another electrolyte defect, that is hypercalcemia, will also cause an abnormality in urinary concentration and reason of nephrogenic diabetes insipidus. It is a list of drugs they cause diabetes insipidus. Lithium and hypervitaminosis of vitamin A and D will cause hypercalcemia, leading to nephrogenic diabetes insipidus. Cisplatin and aminoglycosides will cause hypokalemia, leading to nephrogenic diabetes insipidus. Dimethocycline, amphotericin B, they will cause nephrogenic diabetes insipidus. phenytoin and ethanol will cause central diabetes insipidus. Loop diuretics will cause water loss and diabetes insipidus. Mannitol will cause osmotic diuresis. Corticosteroids will cause urea increase, leading to diabetes insipidus. So how we are going to test which type of diabetes insipidus? This is one simple test is water deprivation test. But first thing we should know normal urinary osmolality is more than 800. Complete central diabetes insipidus, it is very concentrated, very dilute, and the osmolality is less than 300. And in nephrogenic diabetes insipidus, it is partially dilute, and the osmolality is between 300 to 500. What we do first, first we measure this osmolality, then we make the patient fluid restricted for up to 2 to 3 hours, and then we give 5 units of arginine vasopressin. And after 1 hour of giving this drug, urinary osmolality is measured. So, what is the result interpretation? After giving this arginine vasopressin, in complete central diabetes insipidus, there will be substantial increase in the urinary osmolality, because in central diabetes insipidus, the problem is there is no ADH in body. If we are supplementing ADH from outside, there will be a proper response and there will be concentration of the urine. But in nephrogenic diabetes insipidus, the problem lies in the receptor level. There will be circulating ADH previously before giving this external ADH. So there will be little or no response of increase in urinary osmolality in nephrogenic diabetes insipidus. Coming to the treatment part. Treatment of central diabetes insipidus, it may be in acute setting or in chronic setting. In acute setting, where renal water loss are very extensive, aqueous vasopressin has a shorter duration of action that allows for careful monitoring and avoids complications such as water intoxication. This agent should be used in caution patients with coronary artery disease and peripheral vascular disease because they cause intense vasospasm and prolonged constriction. Chronic central diabetes insipidus, desmopressin acetate is the agent of choice. It has a longer half-life, does not have significant vasoconstrictive effects, can be administered intranasally every 12 to 24 hours. This is a table showing the same. In complete central diabetes insipidus, desmopressin can be given in a dose of 10 to 20 mics intranasally every 12 to 24 hours. In partial diabetes insipidus, vasopressin aqueous can be given in 5 to 10 units every 4 to 6 hours. Few drugs like carbamazepine, clofazimine are also useful in partial diabetes insipidus. The treatment of nephrogenic diabetes insipidus, mostly we should correct the reversible causes like correction of the potassium level, calcium level, removal of the offending drugs, low sodium diets, thiazide diuretics, and amyloid also will help in treating the nephrogenic diabetes insipidus. So finally, with this background of knowledge in Euvolaemic hypernatremia, what we can do to correct this first is correction of the water deficit. As in other hypernatremias, we have to calculate the free water deficit and we have to replace giving 0.45 saline or 5% dextrose or oral water. In central diabetes insipidus with severe losses, aqueous vasopressin can be used, and we have to monitor serum sodium levels to avoid water intoxication. And long-term therapy with desmopressin will also help. Now, how to correct the hypernatremia practically? First thing is you have to calculate the water deficit and the ongoing losses of water. For a patient of 60 kg, the percentage of body water varies from 0.45 to 0.6. The percentage of body water is 0.45 for females, 0.5 for males, and 0.6 for elderly people. And the mass is kg, and the water deficit is calculated by percentage of body water into mass into current sodium level, ideal sodium level, that is 140 by ideal sodium level. It will show, this calculation will show how much the water deficit in the body. Then again we have to calculate for the insensible losses, that is 10 ml per kg per day, that comes around 500 ml average per day, and electrolyte free water clearance is around 1 liter. So the total water loss is around 1.5 liters per day, and we calculate the water deficit from this formula. It will add up to the total fluid that should be replaced within 24 hours. This is the first step. Then the second step. This step includes the ad hoc medias formula and the choice of fluid what we are giving. In this ad hoc medias formula, we will able to know the fluid, whatever replacement fluid we are giving, how much it will change the serum sodium concentration in this patient. So the change in serum sodium concentration, the formula is infused sodium plus infused potassium minus serum sodium by total body water plus 1. So if we are using 0.45 sodium chloride in water, the infusion sodium is around 77. 0.9% sodium chloride in water, that is around 154. If we are using 3% normal saline, it will be 514 sodium millimoles per liter. So after calculating how much correction fluid we are giving and how much is the total need of fluid to be replaced, then the third and most important step, the rate of correction. The rate of correction in hypernatremia, it is extremely important to minimize morbidity and mortality. In adult patients who have hypernatremia during short course of time as a result of sodium loading, rapid correction can be done at a rate of 1 to 2 milliequivalents per hour. Lowering of serum sodium appears relatively safe, and the overall 24-hour target should be around 8 to 10 milliequivalents per liter per day. And most of the patients of hypernatremia during days to weeks they develop. So in this group of patients, sodium concentration should be lowered very slowly, and the rate of correction should not exceed more than 0.5 milliequivalents per hour. And the total correction per day should be restricted within 10 milliequivalents per day. By all these things, we are able to correct serum sodium levels. The most important thing is we have to repeatedly see for the signs of toxicity of hypernatremia and volume overload, and serum levels of sodium should be measured repeatedly by laboratory methods during correction of the serum sodium. Thank you.